Hi, Dr. Templeton. You're muted.
Sorry, my clinic ran late.
That was my guess. You're
Yep,
very
I'm
busy,
sorry.
so no problem. Thank you for being here today.
Of
Um,
course. I appreciate the invitation. Thank you.
So we'll go ahead and get started. I think most of you know me. My name is Andrea McMillan. I'm from the Graduate Medical Education Office here at KU, and I also sit on the Sexual Assault Awareness Committee here at the university. And so we created the programming for this week. One of the things that we thought would be an appropriate fit was Dr. Templeton, who always has a large presence inside of the women in medicine, women in science community. And specifically her presentation today is on responding to harassment by a patient. So on behalf of the SAW committee, I want to welcome everyone that is here and also welcome and thank Dr. Templeton for presenting today. Ellie is going to put some etiquette rules for Zoom in the chat for everyone. Dr. Templeton, do you want me to hold any questions in the chat for the end or?
Yes, yeah, that would be awesome. That'd be
Okay,
awesome.
so I can give you just a little 5-minute, 10-minute warning before we're close to the end of the hour, if that works for you.
Sure, that'd
Okay,
be
great.
great.
So Dr. Templeton, Kim Templeton, MD, is a professor of orthopedic surgery at the University of Kansas Medical Center in Kansas City and department vice chair for diversity, equity, and inclusion. She was the first McCann professor for the Women in Medicine and Science in the United States. She received the inaugural Women's Leaders in Medicine Award from the American Medical Student Association in 2008, the Marjorie Sidridge Leadership Award for Women in Medicine from the University of Kansas in 2012, the Elizabeth Blackwell Award for Outstanding Contributions to the Cause of Women in the Fields of Medicine in 2013, and the Bertha Van Hoosen Award in 2019 for exceptional leadership and service to women physicians and students, both from the American Women's Association or those were both from the American Medical Women's Association and was named the University of Kansas Women's Hall of Fame and an honorary alumnus of the University of Kansas in 2014. Dr. Templeton is, did I say that all?
Yeah, and that's fine. That's a great introduction.
Okay.
Thank you.
Okay. Do you want me to do your areas of focus for you? Or
Nope, that's fine.
All right.
That's fine, but thank you. I really appreciate it.
Yes, and thank you, Dr. Templeton. I will hand it off, and I'm excited to hear your presentation today.
Well, thank you. I appreciate that. And thanks again for the invitation. And I appreciate everybody taking time for this discussion. And with any luck, there we go. Hopefully you can see that. So we'll be, as Andrea mentioned, we'll be talking about harassment and discrimination from patients. And I'm thrilled that she asked me to talk about this because this is an area that is critical for women physicians, yet we don't talk about it very much. It's hard enough for us to get to talk about harassment and bias when it's at the hands of a colleague or someone more senior. But it's even harder when we're talking about that coming from patients. I think because as women, we've been trained to be caregivers. And as physicians, we're trained to take care of anybody who comes in through the door, abnegating the impact that they may have on us. And so this is, I think, time to raise awareness of this as we're talking more about harassment and discrimination overall. I think it has to be all comers and then figure out what we can do. So in terms of definitions of harassment, the AMA definition is the fairly standard definition of harassment as being inappropriate sexual advances, sexist jokes or slurs, exchange of rewards for sexual favors, sexual advances, etc. But I think the thing to remember is, especially when we're talking about comments or humor or something along those lines, something other than a physical assault, that something defined as harassment is based on the interpretation of the listener. It is not based on intent. And so people may make what they think are jokes. They may make other comments about your appearance, which they think is funny, but we don't perceive that as funny. And so that, even though it's not intended as harassment, is what it is. And it's the way that we respond to it, like any other type of harassment, with increased anxiety and all the downstream effects of that. Harassment also includes lewd cartoons, emails, letters. We're beyond the stage where harassing things should be thought to be funny. They may be funny to a small segment, but not to everyone. So when we look at sexual harassment, it can be verbal or nonverbal. The most egregious acts are the least common, which is great. Egregious acts meaning sexual assault and rape. Those are the ones that gain the most attention, which is understandable considering how violent they are. But again, fortunately, they're the least common. And what we're dealing with then is not the impact of the occasional assault and rape, which is a huge deal, but it's the daily stuff that we're dealing with either from patients or from our colleagues. Much of sexual harassment is related to implicit or at times explicit biases. It's a power struggle. It is a way to maintain stereotypical gender roles, to maintain a perceived hierarchy. While we see that among those in healthcare, and those in healthcare, I think, understand what they think the hierarchy should be, whether it is that now or not. Patients also still have that hierarchy. They understand in their mind where they think women should fit into the picture. And when we don't, that's where you're at risk of having issues with sexual harassment or biases or AMA on sexual harassment. They talked about sexual coercion, talked about unwanted sexual attention. But under the rubric of harassment, they also brought in gender discrimination, biases such as microaggressions and bullying. And so that now is all. So when I talk about sexual harassment, that's usually all encompassing and includes all of these things, because although they have different manifestations, the impact on women tends to be fairly similar. So who are the perpetrators of harassment? It's our colleagues, so same level of seniority. It's more senior physicians or supervisors, administrators, other healthcare professionals. And then again, as we're talking today, unfortunately, it's also patients or patients' families. So when you look at the various types of biases that women can face, one of the most common for both colleagues as well as patients are microaggressions. Microaggressions are verbal or nonverbal slights or insults that are intended to have negative messaging, usually arising from conscious or unconscious biases, tend to be extremely frequent in nature. In this study of women orthopedic residents or those in fellowship, the overwhelming majority had experienced some form of microaggression during their training. When they were asked then to identify who were the perpetrators, the number one group that they identified were patients and families. And I think especially for women in a field that is 95, 90, well, actually we were 95% male, it's now not only 94% male, but in a field that's overwhelmingly male, where patients likely come in with this preconceived notion that the orthopedic surgeon is going to be a man, and a woman walks in, especially if it's a woman of color, that kind of blows their preconceived hierarchy, and that may be what increases the risk of microaggressions, at least in the population of orthopedic surgery. So where do these microaggressions and other issues come from? The vast majority are unconscious biases, although some may actually be conscious. As we know, everyone has unconscious biases. We do a great job here of unconscious bias training. They tend to develop early in life and strengthen over time, and can lead to blind spots, which may be the sources of some of the harassment, bias, and microaggressions. And it's always important to remember too that the societal issues that we see don't only impact the physicians that we frequently think of as the perpetrators of bias and harassment, but it impacts patients too. So they're coming in with the same societal messaging that we all have. In terms of gender and unconscious biases, we know that there are implicit associations of separate work domains with gender. So men are associated with work and women are associated with family, and men are associated with science and women are associated with arts. So these overall gender links are then generalized to traits, such that men are thought to supposedly be strong, decisive, assertive, tough, etc. Women are nurturing, communal, nice, supportive, helpful, sympathetic. And so when you have this generalization, again, usually unconscious, but patients are coming in assuming that those are the traits that we have. When we come in and we don't necessarily have those traits, then that's where, again, their view of the world has been changed. And one of the ways in which they may react to that are with unconscious biases, so biasing behaviors, harassing behaviors, etc. This study looked at common gendered microaggressions that were seen in the healthcare workplace as interpreted by healthcare professionals. So the 6 main ones that they saw were sexism, pregnancy and childcare related biases, that women's abilities were underestimated, women were relegated to mundane tasks, women were subjected to sexually inappropriate comments, and women often felt excluded or marginalized. But interestingly, they had both men and women faculty look at some of these behaviors and how they were manifested. Women were significantly more likely than men to identify these behaviors as being harassing or biased or microaggressions or to be problematic in the workplace. Those views, again, are primarily societally based. And so you've got to assume that patients are going to have similar attitudes. And so then if you look at studies where the patient is the perpetrator of the biases, many of the microaggressions that patients bring into a physician-patient encounter are pretty similar to those that were identified by faculty. So again, is this the impact of societal gendered expectations resulting in unconscious biases? And then what happens when these biases are continued, but yet we have an increasingly diverse workforce, which is then challenging the preconceptions of patients of who is actually qualified to be a physician and who is qualified to take care of them. So if you look at the range of harassing behaviors from patients, from a harassment standpoint, it's flirting, lewd comments, staring, exposure, physical contact, the things that you would expect from a sexual harassment perspective. But when you look at the gender-based or biased behaviors, these are really similar to the ones that the men and women faculty came up with, that women were not, in the study, patients did not identify women as physicians. Patients were making comments on the physical appearance of women. And patients were defiant when following instructions during a clinical encounter with a woman. So again, trying to restore what they perceive as the hierarchy of the physician-patient relationship, but then seen through the eyes of potentially a male patient and a female physician. So how often and what types of behaviors are seen by physicians? This is a study of internal medicine residents. Who, again, these are some of the biased behaviors that faculty identified, and we're seeing them among patients. In this study, vast majority of these residents face belittling comments. Very few of the men face similar comments. Almost all of the women faced some sort of behavior in which their role was questioned. So they were questioned whether or not they were a physician. All of them at some point were mistaken as non-physicians. Unfortunately, only 15% reported to the behavior to the institution. That 15% is a pretty common number. That's the usual rate of reporting of sexually harassing behavior, no matter who the perpetrator is. So it's a significantly lower number, and we need to make that better. So again, looking at incidents of harassment, in this study, looking at graduating residents at a single institution, significant issue with offensive remarks, whether direct or indirect, microaggressions, threatened with physical harm. Those first 4 categories, the first 4 that I mentioned, were significantly more common to be the result of an interaction with a patient or a patient's family. Only humiliation and shame were behaviors that were more likely to come from a physician. And so these residents are seeing these biases, and they're facing harassment, usually coming from patients in most of these incidents. Unfortunately, the study didn't differentiate between male and female, so I'm not sure what the differences were based on gender of physician. This was a survey of graduating U.S. general surgery residents. Again, you see the dichotomy in gender in terms of the behavior that they report facing from patients. So 2/3 of women and only 10% of men reported facing gender discrimination from patients. Harassment, again, was lower, but still significantly higher among women than it was among men. Among the women who reported discrimination, almost half of it came from patients and family, significantly less from other groups that were assessed. Again, few men reported sexual harassment. Among the, as I mentioned, it was mostly from patients and family. Interestingly, if you look at the men reporting sexual harassment, the most common category of perpetrator were nurses and nursing staff. So women much more likely to be harassed, or at least report harassment by patients and family. Men more likely to report harassment from nurses or staff. But interestingly, actually the largest percentage of men who reported harassment reported that they didn't know who the harasser was, which I find interesting because you would think if you know you were harassed, then you would know who did the harassing. So I wonder if that is, from a male perspective, humiliating to understand and report that you faced harassment. Maybe a societal bias against reporting. But that too, even though we focus a lot of this on women, I think we also need to look at men and see what kind of biases and harassment that they're facing and make them more open to disclosure. This was a study of a single academic dermatology practice, again, looking at incidents. Significantly more women than men experienced sexual or were subjected to sexual harassment from patients. Specific behaviors of patients included comments on appearance, questions about marital status, jokes, etc. But what's concerning is that the women in particular reported multiple episodes of sexual harassment, and women were much more likely than men to have multiple episodes. So this is not just a one and done. It's a reflection of culture. It's again a reflection of power and hierarchy. And so women are going to be at risk of being exposed to this by not just one patient, but maybe multiple. And looking at the last category, a third of them reported up to 50 occurrences over the course of their career. You've got to think that that's got to have some impact on them. This is less of an issue in inpatient settings. I just wonder if that's a power dynamic that physicians are seen as being more in control in an inpatient setting. I don't know, but it's interesting that this is a primarily outpatient issue. And again, looking at intersectionality, we know that at LGBTQ plus physicians face enough issues and may feel a sense of exclusion and disenfranchisement at work. This includes harassment and includes harassment by patients. We just need more data on incidents. So then it comes down to, why do we care about this? What is the issue with harassment? Well, it all gets back down to many things, to the sense of well-being. And if you look at the factors that impact women physician well-being, we usually divide them into intrinsic and extrinsic factors. Intrinsic factors being things like communication style and social isolation, posturism, stereotype perception, and stereotype perception threat. Well, those are usually classified as intrinsic. In my mind, I don't think that they are. I think that there may be some inherent difference, but I think most of this is learned, or it's due to societal exposure. And there are many things in the extrinsic category that I think further impact those that are in the intrinsic category. But when you look at extrinsic, meaning things where we may have a better handle on fixing, the core of extrinsic factors impacting women physician wellness are things that lead to a discrepancy between personal priorities and those of the place in which you work. There are many things that overlap between women and men with this, like EHR and work-home interference and that kind of thing. But the thing that's different for women are the issues with sexual harassment and unconscious or unconscious biases, including issues with intersectionality. So if you think about a sense of having a common value with those in your workplace, if you think about then that translates into belonging in your workplace, what better way to have to acknowledge that you don't belong in the workplace if you're working in a place where you are constantly faced with microaggressions, bias, or harassment. So what happens then to physicians who are exposed to these behaviors? It's a lack of belonging. It feels like you don't belong in that workplace. That may be a contributor to lower sense of well-being and burnout. Even if it doesn't lead to burnout, it's at least impacting physician morale. There's then a risk that women are going to leave medicine. And then if women leave, it's a loss to medicine, but also then what does that do for the future of diversity within medicine if we don't have older women physicians to help mentor the next generation, if they're leaving in part at least because of some of the behavior that they have to face? And so what are the outcomes of some of this discrimination? This is a survey through the Association of Women Surgeons. Women more likely than men, again, to experience or witness harassing behavior, including from patients. And among those who had witnessed or experienced this behavior, they noted a significantly decreased career satisfaction. So we know it does have an impact. This is a meta-analysis looking at harassment and discrimination. Again, showing significant number of harassing episodes were from patients or families. Among women who were exposed to this behavior, they were noted to have an increased risk for depression and anxiety, which depression and anxiety are separate from burnout. They can overlap in some, but not everyone. So this doesn't mean they're burned out, but they at least have issues with depression and anxiety. That can be a reflection of chronic stress and stress response. So this was the same study in the dermatology practice. Among the women and men who had experienced harassment, about 20% of the women experienced feelings of burnout due to harassment by their patients. Men, even if they had faced harassment, did not complain of burnout. Some of the women had to change their practice setting because of practice or patient perpetuated sexual harassment. Some of the women had to terminate the relationship with a given patient because of unwanted sexual related behaviors. And so although in this study, both men and women could be victims of harassment, women, as most studies, significantly more likely than men to face patient-based harassment, the impact was different. Women got burned out. They had to terminate a patient-physician relationship. They maybe even have to change their practice. Men face none of that. So it's calls into question, was the harassment different? Or was it just that their response was different? Or for all of the issues that women in medicine face and that intrinsic and extrinsic list that I showed, maybe this is just one more thing to add on that's causing these women to become burned out. This is a study of ophthalmologists and ophthalmology residents. The study included primarily women, and over half reported episodes of sexual harassment. Almost half who noted that they had been harassed found that the perpetrators were patients. The overwhelming majority of people that faced sexual harassment noted that the harassment had a significant impact on their professional lives, and a small proportion changed their jobs or changed their careers. So that's what we see primarily in those in practice. What do we see among residents? This is a study that Dr. Norville had worked on here in unpublished data, but we're working on trying to get it published, that looked at behavior that residents are facing. This is given all comers. This is not just patients. But the last category, verbally threatened at work, that had a higher proportion of patients than it did of others in the healthcare profession. And what we found, at least for women, is that people that face this kind of behavior are significantly more likely to be burned out. So this behavior does have an impact. This was looking at women that were in surgical training. And again, this is not a one-time or one-off behavior. This behavior can occur on a monthly basis, if not more frequently. What this study showed is that the increasing frequency of mistreatment, whether mistreatment being discrimination, bias, or harassment or abuse, was associated with increasing markers of burnout. So it's not just the harassment that leads to burnout, but the more often you're exposed to burnout or to harassment or harassing behaviors, the more likely you are to become burned out. And these are harassing behaviors on the part of patients. In the study, women were more likely than men to report symptoms of burnout, especially emotional exhaustion. But if you then factored in the mistreatment, the discrimination, bias, harassment, and abuse, if you factor that in, the differences between women and men in terms of symptoms of burnout went down significantly. So it may, at least for this study, be less of a gendered issue with burnout and more the bias and harassment that people are seeing. Likewise, suicidal thoughts were more common among women residents in the study than they were among men. But if you took out the bias and harassment and harassing behaviors from patients, then the differences between genders and suicidal ideation went down significantly. And looking at intersectionality, the study from looking at the AAMC graduation questionnaire, LGBTQ plus students had higher rates of who had higher rates of humiliation and mistreatment were more likely to have markers of burnout, and the risk of burnout increased with the intensity of mistreatment. So we know that this harassing behavior occurs from patients. It's more common in women than men. There are implications. But then why do we need to address it? Well, one, again, because this impacts the well-being of physicians, especially for women. This adds in one more area that causes them to become burned out or potentially leave medicine because of decreased morale. Again, I think we need to know more about men. We know what happens in men. I just worry that maybe they're not reporting because of societal implications, or maybe it just doesn't have that kind of impact in men. Other issues to be concerned about with this sort of behavior is that patient care can be jeopardized or at least disrupt the physician-patient relationship, because it's hard to care for someone when you're facing this kind of behavior from them. And it's important when we're looking at this that we need to look at this as a dyad, that we need to make sure that we're taking care of the well-being of the patient, that they're cared for by, if not us, then by somebody, but also make sure that we're continuing to look at the well-being of the physician. And so what happens with harassment? So if you're going to address harassment, it's like any health issue. You don't know that you're improving things until you know the incidents. And so the incident starts with reporting. Well, we know that reporting of harassment does not happen often. As I mentioned in a previous study, 15% is usually the number cited in terms of how many episodes are reported, no matter who the perpetrator is. And why isn't it reported? Well, there's this thought that nothing's going to be done. There's a concern that the victim wouldn't be supported, that the report isn't going to be confidential, thus leading to potentially negative professional or social consequences. And so if you are concerned, if you report that somebody's going to find out, there'll be negative consequences for your career, and you're not sure what the process is or if anything's going to happen to the perpetrator, that makes it really hard to make the argument why someone should report. And I think it's even harder if the perpetrator is a patient, because at least if it's someone that's in an academic health center, we have ways to get them appropriate training or limit what they do or what their exposure is. If it's a patient, there's not really a whole lot you can do in terms of fixing behavior, and it's more trying to adapt to behavior. On the study on the right, this looked at perpetrators of harassment among women orthopedic surgeons. And so again, you can kind of see from this why there would be concern about reporting if your primary perpetrators are men more senior in their position or patients. That could potentially lead to some significant consequences. So if it's a patient who's been a perpetrator, there's always the risk that you're going to receive a bad online review. There's always a risk that you're going to have a negative interaction that could negatively impact your career. So that could make people less likely to want to report. The processes to report are also at times somewhat unclear, and especially with patients. So if a patient has exhibited inappropriate behavior, then report to whom? And if you do report, then are you going to be supported? If we're the ones that are supposed to be taking care of patients and then we're complaining about their behavior, are people going to side with the patient because they're the ones that came in for help? Or are they going to support the women that were victimized by the patient? So that gets a little bit challenging. There's also the issue with convergent thinking, identifying what is acceptable behavior in medicine. And we as women are, as you know, are trained to put our own needs last, physicians in general, but especially women. So it's hard when a patient's coming in for your help to then have to take a step back and realize you need to protect yourself first before taking care of the patient. That's not inherently how we're trained, either growing up as women or certainly during our medical education, medical training. And our need to focus on and prioritize patient care, and that sometimes is at odds with attempting to remain safe and dealing with inappropriate patient behavior. But if this isn't addressed, if we don't have a better handle on what's going on, if we don't have more reporting, then the culture isn't going to change. And then that gets back to then how do women feel as though they belong in a healthcare setting? So some common themes that you'll see when you look at studies of women physicians who've been victims of harassment by patients and how they responded to that. This was a qualitative study of women physicians. Their response was, by and large, what you see in most studies, is they felt unprepared to respond. They were caught off guard, and then they're trying to, on the fly, figure out how they're supposed to respond while remaining professional, while also trying to take care of the patient. Most of the women in the study noted that they did not have formal training on how to deal with these situations. We may have training and do have training in sexual harassment, but it's mostly in dealing with colleagues and superiors. It's not so much if you're dealing with patients. Many of the women in the study learned how to respond by observing the behaviors that of others and listening to advice. They listened to their peers and their superiors in terms of developing tactics, but many of them also mentioned they didn't have a mentor, so they didn't have anybody from whom to get advice. So again, they're working on the fly. So this is by and large what you'll see is that women are caught off guard. They haven't been trained in how to respond, and then they're trying to scramble on during the visit, trying to figure out what to do. In this study of residents to see how they reacted to patient harassment and how they responded most of the time, either by setting limits, which I think is a great way to go to let patients know very clearly what is and is not acceptable behavior. Talking with family and friends, that's usually the outlet. If you look at this at the reporting, if people don't report to their institution, the vast majority of time they're venting to family and friends, which will provide, hopefully anyway, provide them with support, which they need, and that's great, but that doesn't then translate back to action within the institution. Debriefing with team members, another way to get support within the workplace. Switching care to another physician, which again is a good way to go if you feel uncomfortable taking care of a patient. Again, it gets back down to 15% rate of reporting. And when asked why they didn't report, because they were trying to prioritize patient care, they thought it was pointless to report and so kept caring for the patient. And again, some of them also cited issues with lack of knowledge of the situation, lack of knowledge of the process, and issues again with repercussions. This study was a qualitative study of women physicians looking at verbal harassment from patients. Most of them said that they were unclear of what the intent was of the verbal harassment. They again felt that they didn't know how to respond. And so these responses, these strategies are ones that they came up with on the fly. So this is not anything that they've been trained, but looking at this qualitative study, these are the main themes. Indirect strategies were the most common, in which they tried to redirect the patient, just ignore the comment, avoiding a part of the interview or exam which they thought the patient would think would be sensitive or that they thought could trigger additional harassing behavior. I get that, and I understand how that would be thought on the fly to help, but you may be missing important patient information. So that in and of itself can be a little bit dicey. They used humor, which is a good way to diffuse the situation as long as the patient takes it appropriately and understands that you know that there's been harassing behavior, and that's why you're using humor, not that you're trying to play into some sort of interaction. The women that used this thought this was effective, but they still felt they were caught off guard, and they still felt they left feeling distressed because they hadn't decompressed anyone, they hadn't sought support, they tried to figure it out on their own, avoiding comments, redirecting comments, and that kind of may get the patient interaction completed, but it doesn't necessarily make people feel supported. Some women responded with confrontation. It's especially if there were learners there, they were trying to protect the learners. Interesting, I think it's a woman thing that we are trying to take care of others. Interesting that they would confront a patient to protect a learner, which is great, but not to confront a patient to take care of themselves. They would modify the encounter, trying to be less personable and more distant. Again, avoid parts of the history, keep the door open, have other people there check in. I think it works as long as you are maintaining the patient interaction. The modifying self one, again, I understand, but I think is concerning as you're wearing less or no makeup, changing your hair and your clothing. It's the thing that I find concerning about that is it's almost blaming the victim and making the woman change so that they're not harassed. It's also missing the point that harassment is not about sexual attraction. It's about power and maintaining the unconscious status quo. So I'm not sure how this would work. Wearing a white coat and a visible name tag may help, especially if there are issues with not being respected as a woman physician. Alerting others is great. You document behavior in the chart so that future healthcare professionals understand that this is an issue. And then debriefing with colleagues, although I would like to extend that to ideally debriefing with someone in the institution to see how we change the climate. The outcomes that these women faced is that Many of the patients simply weren't aware that their comments were inappropriate, and they usually apologized. If you get back to the study that I mentioned earlier of women being much more likely than men to identify a given behavior as harassing, that may be what we're seeing reflected here, that we as women are probably more attuned to what harassment against women looks like than men who are doing the harassing behavior. It doesn't get the men off the hook, but it means that we need to have a more open conversation and a more clear boundary setting about what is and is not appropriate behavior. If men don't necessarily see something as harassing, then we need to inform them about what it is and is not harassing behavior. However, some patients did become defensive when they were confronted and told the woman that she's being overly sensitive because they're getting back to blaming the victim. No matter what the response, the intervention, whether they use a direct or indirect approach, none of the physicians had a patient terminate the relationship. So this concern that we can't confront a patient because they might leave is probably not true. The patients will stay, and even if we can't care for them, if we arrange for someone to care for them, they're still getting their care from someone. In this study, looking at what residents were using when they were confronted with inappropriate patient behavior, they used redirecting behavior, making comments, trying to get the appointments back on track. If that didn't work, became more confrontational and telling patients to stop whatever it is that they were doing. The paramount point of this, though, is that you have to feel safe as a physician. And so if you're in with the patient and you're facing harassing behavior, you can try redirecting, you can try more direct approaches, but if you don't feel safe, those probably aren't going to work, and you need to remove yourself from the situation. So all of these things that I've mentioned, the last few slides, have been things that women physicians have come up with, and residents have come up with when confronted with a situation that they didn't anticipate, and they're trying to figure out on their own how to do this. And I would say, in my opinion, this needs to be much more structured, and women need to plan ahead on the assumption that they are going to be harassed by a patient at some point. So when you're confronting patient behavior, first and foremost, consider the mental or physical health conditions that may be contributing to the behavior. Does the patient have some sort of dementia? Is there some other mental health issue that's contributing to the behavior? It doesn't excuse the behavior, but at least you can take that into context and maybe get support with specialists in those areas to help get you through a given patient appointment. Um, you want to support victims in reporting behavior and try to seek interventions in real time. So talk with the patient while they're in the room. If you need to get support, bring them in at that time. If you're going to transfer care to someone else, do it at that time, and try to get things resolved so that women that are faced with this are not ruminating on what happened. Because as you know, women tend to respond to uncomfortable situations with self-blame. That's one of our most common ways that we respond, and blaming ourselves for these interactions is only going to further deteriorate our physical and mental health, because these are not our fault. It's really not a fault. So we can't blame ourselves. So it's really trying to address things in real time. It's training on how to respond to sexual harassment, bias, and bullying, and that's including from patients. And that's training everybody, and it's training everyone to an upstander intervention. So we can not only be there to intervene for ourselves, but for our colleagues. As you know, there are a variety of toolkits out there. This is just one of them. This is from the University of Iowa, looking at toolkits for responding to patient-initiated verbal harassment. And they have two components: how to respond if you're the victim, and how to respond if someone else is the victim. But it's maintaining respect for the patient. It's addressing the behavior rather than the person, so that way you don't get them defensive and even harassing you even more. Making sure that you let patients know how it makes you feel. And again, humor may be to diffuse the situation, but you've got to be cautious because that may be misinterpreted. Set boundaries as needed. Um, Offer an alternative, doctor versus honey. I get called honey a lot. That's where you've got to take the patient's background into consideration. If it's a 45-year-old competent male, I approach that differently than if it's an 85-year-old really otherwise nice guy who's just doing what he does at 85. So redirect, but it's important to at least know how you're being referred to, because that implies how much trust they're going to have in your decisions and how much they respect you as a physician. And reporting harassment anytime it's going to make you feel unsafe. If you're observing harassment or in a trainee or a colleague, again, try to respond in real time, provide support, offer support, and empower our colleagues to respond and to report if they have been a victim, and whether it's whether you're the victim or someone else's, make sure that there's a written record somewhere. One of the people that helped put together that tool then did a study where they used those tools in a pilot workshop. 85% of the people coming in had no experience with this prior to the workshop. What they found is in the 3 weeks following the workshop, participants were significantly more likely to intervene if they experienced or observed harassment. So it's, again, I'm not touting this education. It is but one of many tools out there. But what this does indicate is that thinking about this ahead of time, learning strategies ahead of time on how to protect ourselves and protect our colleagues is effective. And so it's just thinking about this ahead of time. Now, what they did find is that trainees, especially women, may not feel comfortable calling out harassment if the faculty with whom they're working didn't see it as a problem. And again, I would get back to the gender differences in identifying behavior and interpretation. If it's a male faculty member, they may or may not be as attuned to some of the things that we can see as harassing. There's also the erase from the Yale School of Medicine. So expect misbehavior to happen and to identify a plan. Recognize, pay attention to how patients treat you and your colleagues. And I would say pay attention early before the snowball starts going downhill. Develop a script ahead of time so you're not caught off guard. Again, that was one of the common themes, is that women are constantly caught off guard. So I understand it's going to happen. Figure out how you're going to address it, and just have this ready so you're not caught off guard. Reach out for support if you're a victim, or if you know someone who is, reach out to them to help provide support. One study from Japan shows that men have increased risk of burnout if they're a direct victim of harassment. Women have increased risk of burnout if they're the victim, or if they're the secondary victim and see or hear about someone else being harassed. I think because it's a reflection of the workplace. So we need to provide that support for everyone, whether it's you or someone else. And then their E in the erase is to develop workshops and training modules. And I think that's something to discuss. Georgetown has a program for their School of Medicine for their students to stop the conversation, talk with your attending, and then try to get support. But in dealing with these situations, primary question is, do you feel safe in the encounter? If you're starting to get that uncomfortable feeling that you're not sure that you're safe, then you need to figure out what next steps are. So if the patient's engaging in bias or harassing behavior, if you feel safe, then I would ask the patient to stop. Call the behavior to their attention. Again, focus on the behavior and not the patient. You don't want to get personal. As noted by one of the studies I mentioned earlier, women thought that they had less issues in coping with this if they were direct versus indirect. So ask them to stop. If the patient stops, if they're embarrassed, if they didn't realize that how their comments were being heard or perceived, if they didn't mean to be harassing, then great, continue with your care. If, however, you ask them to stop and they stop, but you're still not quite feeling safe because there's just something that's off about the interaction, then you may want to go to the next side of this paradigm, where you leave the room and talk to a colleague, a supervisor, someone else, just to run the scenario with them, and ideally then transfer care at that point. If there can't be a way to try to make the interaction work, you may bring your colleague into the room with you, have a discussion with the patient, with your colleague, about why they too are seeing this as inappropriate behavior. If the patients are pushing back when you state that you think this is inappropriate and say that you're just too sensitive, if you've got somebody else in there who's actually confirming that this is inappropriate behavior, then at least that gives you some support. So it's either taking them into the room with you, trying to see if you can negotiate an interaction where the patient will stop their harassing behaviors. And if they don't, then at that point is when you're looking at transferring care. Again, you want to make sure that you're reporting it, and you want to make sure that you are documenting it so that other physicians coming along after will understand what the patient's behavior is. So in terms of next steps regarding discrimination and harassment, so we can continue to improve patient care, but also make sure we're continuing to improve the well-being of women physicians. We want to change the culture of society so this kind of behavior is not acceptable. We need clear policies about what is and is not appropriate or acceptable behavior, and that's behavior of those in healthcare as well as our patients. Training and prevention, recognition, and management of harassment. So it's understanding what harassment looks like, whether you're male or female, and then understanding or scripting what responses to that can be. Develop an effective, clear reporting structure, because again, we can't change the culture unless we know what's happening and how often this is happening. Um, Again, that's more challenging for situations in which the patient is the perpetrator. So there's really not a place to report other than potentially to someone within your department, but definitely then documenting something in the patient's record. Ideally, there are consequences for perpetrators. That's a large area of discussion now when physicians are perpetrators. It's hard to know what those consequences are for patients, because you're going to continue, you or someone will continue to provide them with care, but it may be a change in physicians. The reason that people are pushing for consequences is that it encourages victims to speak up, because victims will then know something actually will happen, might actually decrease the incidence of behavior. That just gets much dicier and much less clear when you're talking about patients. So it may be just putting something in their chart so that the next person who's taking on their care understands what they're getting into, and may go into the interaction identifying at the beginning what is and is not appropriate behavior and what the boundaries are of the interaction. So thank you very much.
Thank you, Dr. Templeton. So I haven't seen any questions come through on the chat. Do people want to enter questions in the chat or unmute and ask questions? I had a couple. I can do mine to just kick off the conversation.
Sure.
So that was a great presentation. Thank you so
Thank you.
much.
Thank you.
I had a question about, do we know how, there was a lot of information about how the individual can prepare themselves. Do you know of any institutions out there that are doing things to address this with the patient at like the higher levels of care or higher levels of leadership?
I was actually on a webinar last night where we were talking about bias and harassment of women in orthopedics, and Mayo Clinic, I believe, has developed this policy about what is and is not appropriate behavior, whether you're a healthcare professional or whether you're a patient, so that it's very clear what we will and will not accept within the institution. That's the only one that I'm aware of that has developed something. I have not seen it. I would presume that the policies are pretty different between healthcare professionals and patients. But I think at least if you can be upfront with boundaries, what we will and will not tolerate, that we're there to help patients, but that kind of behavior just gets in the way because it makes us stressed out, it makes us anxious. And the more stressed out and anxious you are, the worse you're going to be in the moment and being able to actually provide good care. So I think that, and that kind of education, though, I think is important, again, because I don't think a lot of patients understand how their behavior is being perceived, especially if they're male, and they see this potentially as funny or as part of their world, and they don't see how others outside of their world are interpreting their comments.
I love that. I love giving people the tools to help advocate for themselves, to educate other people. I think that's fantastic. Any questions or comments from the group or?
Okay. Well, again, I really appreciate.
Oh, hold on,
Yes.
Doctor. Go ahead, Antoinette.
I have
Antoinette
a
Redmond.
question about, so you gave several examples from different medical schools and just what just some techniques that they provided. Which, if you had to select one or two, would be your, I don't want to say favorite because that makes it sound like, oh, that's so great, but which one would you like to see us be able to implement here at KUNC?
I liked the erase from Yale because it talks about, you know, understanding that this is going to happen at some point during your career. And unfortunately, as the data shows, more than once. And then thinking about it ahead of time and developing a script. So so you're not caught off guard. You're not trying to scramble on the fly and figure out what it is that you're supposed to do, and what you do may or may not work, but actually have something scripted. And so that is something that I would see implementing for students, residents, fellows, faculty, anyone. Just let them know how to address this. And that's again why I appreciate Andrea and the group putting this topic on the schedule, because this area isn't discussed. I think it's one of those where we just assume patients are reaching out to us for care, and so we've got to tolerate whatever behavior they bring to the table. And I think the time for that is past. So the more we can have an open discussion with students and faculty and everyone just to anticipate this, and then let's have a dialogue about how you're going to address it. The AAMC also has upstander training for those that observe inappropriate behaviors. I think that's great training too. But I think it's beyond just knowing how to intervene when it's someone else, but it's knowing how to protect yourself, identifying those behaviors that are uncomfortable for you, and then developing a script on how to address them.
I like that term upstander. Is it more of an active way to describe than
Yes.
bystander? Is that the
Yes. So the
okay.
thought, so that's something that they've been working at with the AAMC. So as a bystander, you're just kind of standing back and watching. An upstander, you're actually actively intervening, whether it's supporting the person who comes out of the room and they're stressed out because they've been harassed, or you actually go in with the patient and observe the behavior and describe what the boundaries are and are not. And so be there to support the patient. Because again, it makes it harder for the patient to say that somebody's oversensitive and just overreacted to their comments if you've got a second person in there who agrees with the physician and understands that this is not just being too sensitive, it actually was inappropriate.
That's great. Another question I had, I'm not too familiar with the EMR, but I had wondered, and I saw that you talked a little bit about it, about making comments in the EMR. How does that function? Is there like a space that is reserved for people to make notes, or how is that documentable, or where do you put that kind of information so that it's protected?
You know, that is a good question. And it's something that I would like to look at with the hospital to see if we can get it into the EHR. In the old days, before patients had access to their records, you would just put it in their notes. And then if you're transferring the care of the patient to somebody else, you call them ahead of time to let them know what they may or may not face. Now that patients have access to their records, which I'm not saying is a bad thing, it just means that we need to be cautious where we put stuff. Probably wouldn't put that in a note.
Mhm.
That's something I think we probably need to look at if there's a way to flag it. The most experience I had with this was when I used to work at the VA. And if you would have a patient with inappropriate behavior, you open his chart and you've got like red flashing lights and an alarm going off, and you wonder what you're going to face when you go in. So they very much took their healthcare professional safety seriously. It's not that we don't hear, but I mean, they were all about letting you know if there was a patient who had a past history of inappropriate behavior. I think that it was good to know that. I was actually more intimidated by all the alarms and alerts on the computer than I was when I actually met with the patient. So good to know, but maybe went a little bit overboard. But I think if there's any way that we could have something just to document, as long as it's significant, if it's somebody that just makes an inappropriate joke, you confront them, they say, I'm sorry, didn't realize that was, a harassing comment, and then they're done. I wouldn't document that. But if it's somebody where you feel uncomfortable, you confront it, and the behavior does not stop, that's the kind of stuff that I think needs to be in the chart somewhere so that the next physician knows what they're getting into.
Which I'm sure is a very tricky line to define, because if the person that is caring for the patient is burnout because of continued harassment, bias, all of those other
Yeah.
things that we talk about, then would their level of tolerance for behavior be different than somebody who is not as burnout? And
That's a great question, and it probably is. Although is it that their tolerance down, or is it they're just more attuned and they're looking for it?
right.
Well, not looking for it, I mean, they're so used to hearing it that their ears perk up a little bit more. So it gets back
Mhm.
even again to the gender bias and what you define as harassment or not
Mhm.
harassment. So I'm not sure that there does the burnout so much as that you hear it so frequently that you
Right.
even hear it where it likely exists, but it may not be as significant as you take it.
Mhm.
But that's the problem, is that we've got to stop this, because the more burned out people get, the more stressed out they get, the more
Mhm.
they are constantly on edge and constantly waiting for the next microaggression to occur. And that level of stress can only be maintained for a period of time before you start having physical or mental health issues.
So there's a question in the chat. How do we encourage individual departments to offer more in-depth training to their employees on how to respond to sexual harassment? I feel like an individual employee speaking up would fall deaf on the ears versus coming from up the chain.
That's a great question. I'm a big believer, if you're going to create change, in a top-down and bottom-up approach. And in between, you'll probably get some change. So having people come from the bottom up, having faculty or residents or whomever ask for training, have it prioritized from the top that we need to do this training. So between people saying, I need the training, and those saying you need to do the training, then it's more likely to happen. There has to be an institutional incentive in addition to faculty asking to have that training performed, and make it easy for departments. Have standardized training so they're not trying to figure out on their own what it is that they would want to do. If they want to, that's awesome. But otherwise, the easier you can make it, the more likely it is to occur.
We have about 3 minutes left. Any other questions from the group or comments? And Ellie just dropped several resources into the chat. These will be
Awesome.
recorded, so we'll share these recordings out. Dr. Templeton, thank you again for your time, and thank you again, guests, for being here today. It's a valuable and important discussion.
Awesome. Thank you so much. I appreciate it.
Mhm.
Thank you.
Have a great day, everyone.
Thank you.